Today we are going to discuss about tubulointerstitial diseases. So as like in previous lecture, what we were discussing was about glomerular conditions, and we had done all the glomerulonephritis, nephrotic syndrome and nephritic syndrome, and the primary conditions which can cause these conditions. Of course, like I did not discuss the secondary conditions. So what is tubulointerstitial diseases? Again, like if you know what is the structure of nephron, there is glomerulus, there is proximal tubule, there is loop of Henle, there is distal tubules, and there is or distal convoluted tubules and proximal convoluted tubules, and there is collecting ducts. So tubular disorders are all like there are many different type of tubular disorders. Okay, so as we know that all the diuretics also work or act on these tubules and all these areas like proximal tubule or loop of Henle or distal tubule or collecting ducts, they are doing important functions. For example, proximal tubule is the one where you can say or the sodium, bicarbonate, phosphate, glucose, and amino acids are reabsorbed. And distal tubule is the one where sodium potassium chloride pump is there, or sodium chloride pump is pumped out or inside. And collecting tubule is the one where antidiuretic hormone is the one which affect. So there are different type of tubular pathologies. For example, there are some congenital disorders like Fanconi syndrome, type 1 renal tubular acidosis, type 2 renal tubular acidosis. There is one thing called as Bartter syndrome or Gitelman syndrome. So there are different conditions like this. Like what is Gitelman syndrome? What we are talking about is the tubular disorders, right? Right now, for example, like I was talking about um, Gitelman syndrome. Uh, like this is a syndrome which basically is um, due to congenital causes. Okay. Now, like thiazide diuretics, they work at the distal convoluted tubules, right? And what happens, like in Gitelman syndrome, that it's also referred as or called as familial hypokalemia hypomagnesemia. Okay, familial hypokalemia hypomagnesemia. So as the name shows, it's an autosomal recessive type of condition in which like there is low blood level of potassium and magnesium. Okay, so and the blood pH is elevated. Okay, so now the important thing about this one, like why I'm talking about this one here, is there is a mutation, and there is due to that mutation, there is like the thiazide sensitive sodium chloride transporters which are present in the distal convoluted tubules. They are not functioning properly, right? So when they are not functioning properly, so that's why all these things occur, like low potassium levels in the blood as well as low magnesium levels in the blood. Okay, so now like this one is of course a congenital type of condition. So like I was just like this what I'm talking about, just to give an example of tubular conditions and why it is important to understand the functions of proximal tubules, loop of Henle, or distal tubules. So though most of the people who have Gitelman syndrome, they are asymptomatic and nothing much is needed in these patients. Okay, but just what we do is like we keep on providing them with potassium and magnesium, what you can say, supplements, of course, like because that is what is deficient in the blood, right? So thiazide diuretics, like they work on the distal convoluted tubules. Okay, so a very important syndrome, which is also called as Fanconi syndrome. Okay, Fanconi syndrome. So now Fanconi syndrome is the one which is basically affecting, you can say, the proximal convoluted tubule, right? So in Fanconi syndrome, what happens is again, like this is a like in this one there is the kidneys cannot absorb the nutrients or all the things which are absorbed in the first part of the tubule or the proximal convoluted tubule, the amino acids and glucose, all these things. Like in Fanconi syndrome, the kidney cannot absorb that. Okay, absorb that back. So, or there is inadequate reabsorption. So, for, of course, like well, like when there is inadequate reabsorption, so all these things, well, the body will lose. Okay, so now this one Fanconi syndrome can be congenital, okay, or can be due to can be acquired, like due to some poisoning due to heavy metals. So now what happening, by the way, when in the proximal convoluted tubule where much of the sodium, amino acids, glucose, and all these things are reabsorbed. Okay, so what happened, like we lose these things in the urine, so the urine will be full of glucose, full of amino acids, and full of bicarbonates. Okay, like all these things we are going to lose in the urine. So now the patients, who have Fanconi syndrome, they present with polyuria, polydipsia. Why? Because we had already done diabetes, and whenever there is increased glucose load in the urine, of course, that we are going to have lose more and more glucose, we lose more and more water, so there will be polyuria, and the patient will feel more and more thirsty. So polydipsia, and it can lead to dehydration. So um, now, because we lose a lot of important nutrients or important things which are important for the body, so the body present with low calcium levels, like it can present as rickets in babies or osteomalacia in adults. Okay, and there can be growth failure, there will be acidosis, there will be hypokalemia, so on and so forth, right? Like this thing. So of course, like Fanconi syndrome, of course, whenever it is congenital, so it can lead to rickets in the children. So what is the treatment? Of course, we have to replace all these things in the body, because like the kidneys, they keep on losing this thing. So, but that, like this is about Fanconi syndrome. Now there are many others, like there is renal tubular acidosis and all these things, right? So there are different conditions which are related to the proximal tubule. Like I gave you the example of Fanconi syndrome. This one is like the condition of which affect the proximal tubule, right? And not just this one, by the way. There are many other conditions which can affect the proximal tubule, like um, type 2 RTA or type 2 renal tubular acidosis. Okay, so what is this type 2 renal tubular acidosis? Is basically in this one, um, the kidney cannot reabsorb bicarbonate. Okay, so now the thing is that the bicarbonate is reabsorbed at two places. Okay, one at proximal tubules and one is at distal tubules. So of course, like in this one, the proximal tubules cannot reabsorb bicarbonate, but the distal portion is intact, it still function. Okay, so most of the time this type 2 RTA or type 2 renal tubular acidosis, or we can also say it as proximal renal tubular acidosis, is associated or comes with in combination with Fanconi syndrome. Okay, So it can be a side effect of different drugs, antiretroviral drugs. So how we diagnose this thing? Simply, um, there is increased bicarbonate loss in the urine. Okay, and when there is, we are going to lose more and more bicarbonate in the urine. Of course, like the pH of the blood will raise, will become alkalotic, because bicarbonate is the base. Okay, sorry, the pH of the urine will become alkalotic, right? Because we are losing more bicarbonate in the urine. So now the treatment is, of course, bicarbonate replacement. So, and the diuretics which act on the proximal tubule is mannitol or acetazolamide. Acetazolamide is basically, carbonic anhydrase inhibitors. So these are the diuretics which act on the proximal tubule. So same story with the loop of Hanley. Remember loop of Hanley, the drugs or the diuretics which work on the loop of Hanley is furosemide. Okay, so Fanconi syndrome is a condition of proximal tubule, and the diuretics which work on the proximal tubule is mannitol as well as acetazolamide. Okay, and then we are talking about okay, like the loop of Hanley. You know, there is one syndrome called as Bartter syndrome. Bartter syndrome. Now, what happens in this one is like, if you know, loop of Hanley is very important, especially the ascending thick loop of Hanley is very important. Here, where much of the sodium is reabsorbed, like 10 to 30% of the sodium, and of course other electrolytes as well. And the key, what you can say, channel which is here is basically sodium potassium chloride co-transporter. So what happens in Bartter syndrome? Uh, Sodium reabsorption increases, okay, in exchange for potassium and hydrogen. So what happens in these patients is like hypokalemic, hypochloremic metabolic alkalosis. Hypokalemic, hypochloremic metabolic alkalosis. Because of sodium potassium chloride transporter, what will happen when more and more sodium will be reabsorbed in the body? So what we will lose like is potassium and chloride. So that's why it will lead to sodium, potassium, sorry, hypokalemic, hypochloremic metabolic alkalosis. So of course, like Bartter syndrome, it is a congenital type of disorder, like it presents in childhood, and it has different subtypes. Okay, so now the diuretic which work on this one loop of Hanley, remember it's loop diuretic, furosemide or bumetanide, like this. So then comes the distal tubules. Okay, distal tubules. Okay, distal tubules are the one, where thiazide or thiazide like diuretics they work, right? And what is the main function of distal tubule? Of course, there are many other functions. It reabsorbs what is left sodium, right? Most of the sodium is reabsorbed in the proximal tubule. Then 10 to 30% is reabsorbed in ascending loop of Hanley, and the remaining 5 to 10% is reabsorbed in distal tubule. So it also reabsorbs many other electrolytes, okay, and the main channel is basically sodium chloride co-transporter, and this is the one where this syndrome okay, I don't know what's wrong. So this one, this syndrome, Gentleman syndrome. is the one which is like related to distal tubules. Okay. So what is Gentleman syndrome? As I already told you, there is gene mutation and there is loss of sodium chloride co-transporter. Okay. So this one is, a milder form of Bartter syndrome. You can say this thing as well. So many of the patients, as I already told you, they are asymptomatic. Okay. So the diuretic which act here is like either thiazide diuretics or thiazide-like diuretics, indapamide and all this one, metolazone. Sorry. So of course, like they inhibit the sodium chloride transporter and they decrease the sodium chloride reabsorption. So like the people, they lose more and more sodium and chloride in the urine. So of course that's why it is used to control or to treat the blood pressure. Okay. So again, like this is like more pharmacology related, like what is the mechanism of action of these diuretics and all this stuff. Like if the loop diuretic like furosemide is the one which is acting on the loop of Henle, so of course what they are doing, they are blocking the sodium potassium chloride co-transporter which is present in loop of Henle. So simply they will not allow the reabsorption of sodium and chloride, and like there will be increased loss in the urine of sodium and chloride as well as phosphate, magnesium, calcium, potassium, hydrogen. Okay. So that's what this one is used. And the last one is like collecting duct. Okay. So in collecting duct, what is the more? Remember, like I told you, radial RTA type 2, right? That is here in the proximal tubule, RTA type 2, right? So proximal tubules, right? So this is the one which is RTA type 1. So collecting duct is related with renal tubular acidosis type 2. Okay, or you can say distal renal tubular acidosis. So in cortical collecting ducts, by the way, the aldosterone is the one, uh, which acts here and to retain sodium and of course like to excrete potassium. So in renal tubular acidosis type 2, what happens, like there is failure of H plus excretion. So it could be primarily genetic condition, or it could be due to secondary to many other conditions like drugs like lithium. So now the diuretics which act on the collecting ducts is potassium sparing diuretics. Like clinically they are very important, as well as aldosterone antagonist, spironolactone, eplerenone, amiloride. So of course, like they spare the potassium, they don't let them lose this thing, right? So there are different tubular disorders, but of course, like our main discussion today is about acute tubulointerstitial nephritis or acute tubular necrosis, as well as um, chronic tubulointerstitial nephritis. Okay, and then we will study one more condition called as ATN, which is acute tubular necrosis, right? So when we say tubulointerstitial diseases, so we mean to say tubulointerstitial nephritis. Sorry, interstitial. Okay, nephritis, right? So by definition, tubular interstitial nephritis means what? Like, of course, there is nephritis. Okay, so uh, any condition which is going to, you can say, damage the tubule and as well as the interstitium. See, before we were studying the conditions related to glomerulus, right? So what we are studying until now in nephrology is the glomerulus, right? Sorry, nephron. So nephron have different parts. So the glomerulus part we have already covered. Now what is left is the tubule part and the interstitium which is there. So we had done glomerulonephritis. So what we are going to do now is tubulointerstitial nephritis. Of course, like any condition which is affecting the renal interstitium and tubular cells, and causing inflammation of that, it is called as tubulointerstitial nephritis. So by definition, like cellular infiltrates affecting primarily the renal interstitium and tubular cell. Okay, it is called as interstitial nephritis. So now, see, whenever like glomerulus is damaged, so what will happen? Glomerular filtration rate can decrease, right? But tubules are doing a lot of functions, like the functions of reabsorption or secretions are done by the tubules, no matter it is proximal, loop of Henle, distal, or collecting. Okay, so of course, like the tubules are doing a lot of functions. Even the interstitium or the fluid which is around the nephrons, they are also doing a lot of function, like they are concentrating the urine. Okay, so like this thing. So now we classify tubulointerstitial nephritis into acute and chronic types. Okay, there is acute tubulointerstitial nephritis and there is chronic tubulointerstitial nephritis. So what happens, again, like we are going to discuss with first of all signs and symptoms, then we are going to discuss more about what you can say tubulointerstitial nephritis. So now, most of the times this tubulointerstitial nephritis occurs due to reaction to the drugs. And the most commonly drug is penicillins or NSAIDs. Okay, like most commonly you can say tubulointerstitial nephritis. Okay, tubulointerstitial nephritis is caused by reaction or hypersensitivity reaction to the drugs. Okay, and most commonly drugs are which one? NSAIDs. You remember, NSAIDs we don't use anyone who have like kidney issues, right? And penicillins. So very, very, very important point. Okay, so like you must know the most common cause of this thing. And whenever like this is the case, we simply call it as what? Drugs induced tubulointerstitial nephritis. Drugs induced tubulointerstitial nephritis, right? So the signs and symptoms which we are going to cover in this one is collectively for both of them, no matter it's chronic or it's acute. So first of all, of course, it is obvious, like depending on the site of tubule, okay, or site of tubule affected, okay, we are going to get the sign and symptoms regarding that. So for example, if the proximal tubule is affected, there will be different signs and symptoms, loop of Henle, distal, or collecting, right? So the sign and symptoms will be different. For example, now again, like in my why I told you this story, there was a reason. That's why I started my point from there. That what will happen if proximal tubule uh, is damaged. Okay, so like proximal tubule can be damaged in multiple myeloma, okay, or in heavy metal poisonings, right? So what can happen? See, what can happen when proximal tubule can be damaged? So the patient will present with Fanconi syndrome, right? So now I already explained what is Fanconi syndrome. Like the proximal tubule cannot absorb anything, and the proximal tubule is the site where most of the absorption of all the things which I told you, even the glucose or amino acids and all these things, even sodium, they are absorbed over there. So whenever the proximal tubule will be involved, so what will happen that there will be increased glucose in the urine, glycosuria will be there, there will be increased amino acids in the urine, amino acid urea will be there will be increased phosphates in the urine, so phosphate urea will be there will be increased uric acid in the urine, so hyperuricosuria will be there, right? So see, if you had a concept like this, that proximal tubule, what are the functions of proximal tubule, and what will happen when the proximal tubule is damaged, then you can think easily like how the patient will present. So when we found that someone urine have glucose, of course it is diabetes mellitus, but when we found someone urine have glucose with amino acids, with phosphate urea, or with phosphates and with uric acid, then it can be what? Hyperuricemia. The other condition which I told you about proximal tubule is which one? Type 2 or proximal renal tubular acidosis. And what I told you, see, remember the proximal one or type 2 is the problem with bicarbonate reabsorption, and type 1 or distal is the problem with hydrogen reabsorption. So this type 2 or proximal, okay, it is also called as what? Type 2, right? So type 2, it is what, like there will be decreased reabsorption of bicarbonate, so the pH of urine will be alkaline, simply, right? So it's not a big rocket science. So how the sign, will be the sign and symptoms when there will be distal tubule problem, or when distal tubule is the affected site? Okay, so again, like distal tubule can be affected in multiple conditions. There are many conditions, okay? For example, I will just tell you one. Amyloidosis can cause this thing, right? So when the distal tubule is involved, so what can happen? In this one there is proximal RTA, in this one there will be distal renal tubular acidosis, right? Or which is also called as type 1, okay? Right? This is also called as type 1. So what is this type 1? What's going on? Like there is problem with the hydrogen ion secretion, right? So they present with this thing, they present with sodium wasting, nephropathy, okay? So one of the thing, which can occur in distal tubule problem, which is type 4 RTA, okay? So what is type 4 RTA or renal tubular acidosis type 4? What happens in this one, like there is reduced renal bicarbonate production, which is caused by hyperkalemia, okay? So this is like how the patients will present of type 4, distal tubule problems. And collecting ducts can be the affected site, for example in sickle cell anemia, or polycystic kidney disease, right? We are going to study this one also. So whenever the collecting ducts are affected, remember the urine cannot be concentrated. because this is the part, where ADH is concentrated, right? So this is the part where ADH works, right? So of course, like, they will present with diabetes insipidus, right? And they present with polyuria, of course, right? Concentrated. So these are the patients who present with diabetes insipidus. So these will be sign and symptoms related to either the patient have whenever the patient have tubulointerstitial nephritis, right? So our first discussion is acute tubulointerstitial nephritis, right? So this is our first discussion. Acute tubulointerstitial nephritis. Okay. So what happens in these patients, by the way? It is acute. So first of all, like, what is acute? Like, it occurs within days to weeks, right? And there is decline in kidney function or renal function within days to weeks. Okay. And there are different causes of this condition, right? Again, like, this one is taken from I think Kumar and Clark's, right? You can see, like, it could be as a hypersensitivity reaction to the drugs, which is the most common cause. It could be due to infections. It could be due to idiopathic. It could be due to immune problems like these conditions, or it could be due to tubulointerstitial nephritis with uveitis. In that case, it is called as Steno syndrome. So you can see over here the drugs, which causes most of the time the acute tubulointerstitial nephritis is antibiotics. Okay, these are the names of antibiotics. Analgesics like NSAIDs, diuretics can cause. Many other drugs can cause as well, right? Infections can cause. Whenever it is caused by drugs, it is called as what? Drug-induced acute tubulointerstitial nephritis. Whenever it is caused by infection, it is called as infections-induced acute tubulointerstitial nephritis. Okay, and whenever it is caused due to the causes other than drugs and infection, we can call it as acute tubulointerstitial nephritis as a part of multi-system inflammatory disease like SLE. Okay. And what is Steno syndrome? Like, say 5% of the time, this is a syndrome in which there is uveitis. Okay, inflammation of the uveal tract in the eye, and there is, of course, tubulointerstitial nephritis. Mostly occur in the children, and mostly occur in female, like girls, small baby girls. Okay, so now what's important in this one is, like, these are the causes of this the patients. Okay, and the cells become inflamed. Okay, there is inflammation of the tubules and the renal interstitium, and the patient, they present with now the presentation, of course, is different because the causes are very much different. So here, like, we have to understand few things. Of course, the clinical features will be the features of, you can say, acute kidney injury, right, which we are going to study in the next lecture. And whenever it is a hypersensitivity reaction to the drug, so due to that hypersensitivity reaction, the patient can present with fever, skin rashes, or arthralgias, and so on and so forth, like systemic infections of hypersensitivity reaction. Okay, and of course, like, sometimes because many of the time it can lead to pyelonephritis. Okay, so in that case, there will be flank pain can be there. So most of the time, it occurs like if it is in relation to the drug, so it occurs within 7 to 10 days after exposure to the drugs. Okay. And of course, like if it is related to infections or systemic conditions, so you will found symptoms and signs of the underlying cause, right, or an underlying disease, right. Of course, in SLE you will find the sign and symptoms of SLE. In hantavirus, hantavirus is the one which causes that hemorrhagic fever. Okay. So what we do is, like, of course, we go for urine analysis. Okay. And we can do a blood workup. Okay. CBC, ESR, CRP. Okay, these things. um, what you can say, we can do scanning, or gallium scanning can be done of the kidneys. Okay. And of course we can go for a biopsy. Remember, biopsy is the mainstay, because it is going to tell us the condition of the kidney. So, like, in the urine, of course, like, depending on what is, see if it is proximal tubule, distal tubule, whatever, like we have discussed, in urine analysis we are going to get the report related to that. Okay. We can have hematuria, we can have proteinuria. If, for example, uh, it is due to hypersensitivity reactions, we can get eosinophils in the urine. If it is nephritis, or some, we will get, of course, like infection is there, pyelonephritis is there, we can get WBCs, we can get the pus, all these things. So when the kidneys are damaged, of course, like in blood workup, you will find that the urea and the creatinine is raised. Okay. Again, if it is due to hypersensitivity reaction due to drugs, so you will find eosinophilia in the blood. Okay. And depending on the site of the damage, you can find anything like hyperkalemia or hyponatremia or hypophosphatemia, things like this, right? So how we treat these patients, acute tubulointerstitial nephritis? See the causes. What is the treatment? Stop the offending. If it is occurring due to drugs, stop the drug. Stop the offending drug. If the patient is having pyelonephritis, flank pain with costovertebral angle tenderness or renal angle tenderness, these are the features for pyelonephritis. Put them on antibiotics, okay? If it is due to some immune problem, we can give them corticosteroids or immunosuppressants, things like this. Okay, now when, of course, like we will study acute kidney injury, you would understand how we deal these conditions, okay? There is no medications like this, like you will give the medication and the patient kidney functions will be fine again. Rather, it is more like wait and watch type of theory. So, of course, we treat the underlying cause. That's a very important thing. Sometimes the recovery takes up to more than 2 weeks. Okay. So there are different studies, like how much, how much time it takes for the kidneys to repair. Sometimes it is within 2 weeks, sometimes within 1 month, but rarely, like, you can say, as the time goes on increasing, the chances of recovery is less. Okay. So see this one, like, this is the normal reflux nephropathy, like, the reflux is there. In pediatrics we have studied this thing. See the collecting ducts here, and this is in papillary necrosis. Spurs can be seen, hooks can be seen, renal sign, slog papilla, and there is no loss of cortex, but here there is loss of cortex. So anyhow, we are going to cover with go with chronic um, tubulointerstitial nephritis, right? So now, what is chronic tubulointerstitial nephritis? Simply, it is slowly progressive renal failure. Slowly progressive renal failure, right? And what happens in these patients? There is uh, the signs of abnormal tubular function, okay, with signs of abnormal tubular function and moderate protein urea, okay. So now we'll talk about this one, chronic tubular interstitial nephritis. uh, there are different causes of chronic tubular interstitial nephritis. You can see from here. So what you will see, what you can see over here is uh, drugs and toxins, diseases like diabetes, sickle cell disease, SLE, vasculitis, sarcoidosis, metabolic conditions, infections, and other causes like hypertension, Balkan nephropathy, herbal nephropathy, Alport syndrome. So what's going on in this one? Like there is tubular atrophy and there is uh, protein urea and there is abnormal tubular function, right? So the patients, they usually present with polyuria and nocturia. Nocturia means like during the night, they have to go. And the protein urea is like, of course, less than 1 gram per day. Okay. So what happens? Like I show you this diagram is basically there is papillary necrosis with ischemic damage to the papilla, which can occur in these patients. Okay. For example, when they are associated with different conditions like diabetes or sickle cell disease. So the patients who have uh, chronic interstitial nephritis, what happens? Like the most common cause, by the way, of this one, chronic tubular interstitial nephritis, is urinary tract obstruction. So urinary tract obstruction can give chronic interstitial nephritis. Okay, this is the most common cause, by the way. So what happens is like, of course, whenever there is like obstruction, so due to anything like stones or tumor or bladder outlet obstruction, like BPH, benign prostatic hyperplasia. Okay, so what happens? Like there is black backflow of the urine, right, in the collecting duct, and they can damage the collecting ducts as well as the other structures. So this type, right, is the most common cause. Okay, so it is like simply chronic tubular interstitial nephritis due to reflux nephropathy. Okay. Otherwise, it could be due to drugs and toxins. Okay, so the drugs can be exogenous, like which are you are taking from outside. Okay, like NSAIDs, which is the most common cause, lithium, cyclosporin, lead. There are some Chinese herbs as well, which can cause this thing, or it could be a endogenous toxin or drug. So these are all the causes, right? of chronic tubulointerstitial nephritis. So now, what is the difference between the chronic and acute is simply, you can remember by this one, because chronic, there is chronic insult going or happening to the kidney, it will lead to fibrosis of interstitium. Okay, and there will be atrophy of tubules. Okay, so this is the thing, and of course the cells will be infiltrated. And the signs and symptoms are basically depends on the underlying etiology of this one. So again, we can do the same things. We can go for urine examination, urine labs. We can do blood labs. Okay, we can go for imaging like ultrasonography. Okay, and depending on these things, like depending on the cause, of course, we can get our results. The patient present in the same way, like polyuria, polydipsia, or depending on the underlying conditions, of course. And the treatment again remains same. We have to treat the underlying condition. Okay, if there is offending drug, stop it. If there is any other condition, treat it. Okay, and one thing which is there is like stop the offending drug. You can say treat the underlying cause. Okay, and replace what is missing, or you can say correct the electrolytes or and metabolic abnormalities. Okay, of course, like that's a very important part. Okay, if there is any calcium is less, of course, provide that. If it is more, do something. So things like this, right? So this is how we treat the patients of chronic tubulointerstitial nephritis, right? So, like in the books, like what I use is Kumar and Clark's. You can found analgesic nephropathy. They give the examples of NSAIDs, okay, and what you will found, like the presentation is like they can present with anemia, UTIs, hematuria, and things like this. Okay, many people, of course, they abuse these drugs. They take them almost daily. And what I was talking about, like that, there are some Chinese medications as well, which can cause this thing. So one is called as aristochek acid. So this is like there are many Chinese herbal medications, so which can cause this type of nephropathy or chronic interstitial nephritis. So this one is a drug, and this one is like used nowadays in many Western countries for slimming, for losing weight. Balkan nephropathy. So Balkan nephropathy can cause chronic tubulointerstitial nephritis. Okay, and this is the name Balkan is basically given due to the area Balkan, if you know, near modern day Turkey. There is Balkan region is there. So the people over there that in that region, they use like they had a nephropathy, and uh, actually it is not known uh, why they had this thing. Okay, so like some of the people they did a research like that. Many of them, they have like chronic dietary poisoning by the same Chinese herb, aristolochic acid, right? So they found this thing. Okay, so maybe like it is present in the blood, in the water supply which they were having. Okay, because some of the people who live like on one side of the hill, they had that, and on the other side of the hill they don't have that. So that's why like they found this thing, right? So like this is chronic tubulointerstitial nephritis, and the last thing which we are going to discuss in this lecture is called as acute tubular necrosis. Okay, so now there is acute tubular necrosis. Necrosis is there. So what happens in these patients is like basically there is uh, ischemic or nephrotoxic insult. Like it is the simplest definition of this one can be um, abrupt and sustained decline of glomerular filtration rate within minutes to days after ischemic or nephrotoxic insult to the kidney, okay, or the tubules, right? So the GFR is reduced very, very, very quickly in these patients, okay, and like there is increased loss of fluid, increased loss of electrolytes because the tubules are not functioning. Remember the word necrosis. Now necrosis is there, and the GFR is reduced so fast, So simply like as you know, it could be like acute tubular necrosis (ATN) could be due to two main conditions. One is like ischemic insult, ischemia is there, okay, or second one is toxins can be there, okay. And whenever it comes to toxins, again, guys, remember the story remains same. Either it could be inside toxins or outside toxins. So see, whenever it is ischemia, what can be the causes? Hemorrhage. Hemorrhage can be there, right? Or vomiting can be there. Diarrhea can be there. Like simply of all these things, they can lead to decreased blood pressure or decreased blood supply to the kidneys, right? Or for example, in heart failure, okay, heart failure, what is going on? Like that, the heart cannot supply enough blood to the kidney. Of course, there can be ATN or liver failure. Okay, SITs, decreased intracellular volume is there, decreased circulating volume is there, so they can have this thing. Or sepsis, in which like or anaphylaxis, like anaphylaxis or sepsis. What is going on? Like there is decreased intravascular volume, okay, or there is, you can say, renal artery thrombosis. So see, whatever is the case, you can see over here, the ultimate thing is like either there is decrease in circulating volume, there is decreased effective circulatory volume, or there is decreased blood supply, like due to occlusion of the vessel. It can lead to ischemia of the kidneys, right? And toxins, as I told you, remember it could be endogenous toxins or it could be exogenous toxins, okay, like the toxins which can come from inside or outside. So for example, sometimes the muscles, they can get damaged and they can release myoglobin, which can go and damage the kidney, or um, hemoglobin will go and damage the kidney, or you can say it's a type of infection, like when the bacteria, they are releasing endotoxins and they can go and damage the kidneys. So these are the examples of endogenous toxins. And exogenous, like again, antibiotics, okay. Aminoglycosides are, remember, they are nephrotoxic. Amphotericin B is also nephrotoxic. Antiviral drugs, they can cause enterotoxic. They can be nephrotoxic. Or anti-neoplastic drugs like cisplatin, methotrexate, contrast media, which we give for many studies to take imaging. We put contrast in the blood, they are nephrotoxic, okay. Heavy metals are nephrotoxic, as well as like many others are there, but like you must remember one, two names, right? So what happens in these patients, whenever they have acute tubular necrosis, or what is the clinical features or signs and symptoms in these patients is like there is increased rise of sodium, sorry, what you can say, urea and creatinine, because the GFR is down. So the patient may have hypotensive episodes. Okay. So uh, the patient, what you can say, sorry, there can be abrupt increase in creatinine and urea after hypotensive episode. Okay, what I'm talking about is basically this one. All these things will cause what? Of course, these two will cause hypotension, right? And this one maybe will not cause hypotension, but what will happen, like it will cause like less delivery of the blood to the kidney. So after hypotensive episode, sepsis or rhabdomyolysis, like when there is crushing injury to the muscles, of course, like many of the things will be released which can be nephrotoxic. There will be increase in creatinine and urea, okay, in the blood. So the clinical presentation in acute kidney injury, guys, there will be no much clinical features, but like there will be lab features will be there, right? So what happens, like of course, like we send the patients to the labs, okay, and we inquire, what's going on. So we can go for blood workup, of course, okay. And what in the blood workup, you will go for CBC. You can check the electrolytes levels, okay. You can check the blood urea, nitrogen. You can go ask for creatinine levels. You can check for calcium levels, phosphate levels, or all these things, of course, like very important, because all these things will be disturbed in acute kidney injury, okay. We can go for urine labs or urine workup. We can check like what kind of electrolytes there in the urine, what is the osmolality, what kind of cells are there in the urine, either there is any cast cells are present or not, okay. There can be certain rise of potassium in the urine, in the blood, so we must go for ECG, because remember they can lead to arrhythmias. We can go for abdominal ultrasonography, okay, to check for the kidney, right? So of course, like our investigations are to look for all these things, right? On history, you will ask for this, on or this, or hemorrhage. On examination, we will see the signs of heart failure, renal failure, liver failure, and on investigations, you can rule out. Uh, Clinical features can tell you about anaphylaxis. On investigation, you can rule out renal artery thrombosis or myoglobinuria or hemoglobin or all this endotoxins, right? So that's why we go for all these investigations to rule out all these causes, right? So now, whenever the patients they have acute tubular necrosis, what happens is like uh, we can just give supportive therapy, or supportive treatment can be given. Of course, like again, there is no medications to deal with that, immediately. So if like the kidneys they are not making urine at all or no diuresis going on, we can give them loop diuretics. Okay, they are quite helpful. Can help in volume overload. Okay, to decrease the volume from the body. So, and one of the things that it is believed that they reduce the tubular metabolic requirements, though like this thing is not proven completely. But one thing which is proven, like they can reduce the volume overload. And of course, like whenever the kidneys are not functioning, so of course we cannot give any medications which can help instantly. But to deal with this condition, of course, the one and the only thing which can be done in emergency is dialysis, right? So Acute tubular necrosis can be prevented in number of ways, like see, for example, we must avoid these conditions. Okay, whenever we have to go for an investigation in which contrast media are used, what can be done before giving contrast medium. We give them more and more IV fluids before, to dilute the contrast medium as much as we can. Okay, so anyone who is a patient of chronic renal failure and they need a radiographic contrast medium, so N-acetylcysteine can be given 1 day before the procedure, and then we give them sodium chloride or normal saline solution, isotonic fluids, to make them more hydrated. Okay, and after the procedure, we can give them again IV fluids. Avoid giving diuretics to them, ACE inhibitors or cyclosporin on the day of the procedure because they can increase the toxicity. And nowadays, by the way, all the drugs, and everything, if you will see the leaflet, they tell you like what if, like what is the dose adjustment, like if anyone have any renal condition and things like this. So like this is all about acute tubular necrosis. So these conditions, to understand these conditions, of course, like a very important thing is to understand how the kidney function, or at least knowing the important functions of the kidneys, nephron, the different parts like proximal loop of Henle, distal and collecting ducts. Thank you so much, guys.